afternoon. At the very beginning, I would like to thank the Cambridge Centre for International Research for this opportunity of speaking on a topic that means a very lot to me. I would like to also thank the Professor Ulf Detmer, who guided every step of the research I'm conducting, and Angela-san for being the most caring, patient and understanding teaching assistant I could ever dream of. So, as introduced, my name is Kornelia. I'm from Poland, and today I'm going to talk about the subject that, to be honest, I find the most interesting from all the fascinating ones in neuroscience, which is the usage of stem cells in Parkinson's disease treatment. And I would like to begin with a brief introduction on both the disease I decided to focus my research on and the stem cells used in the therapies, which, in my opinion, are at the moment the most promising treatments being introduced in today's science. So the first question could be, what is Parkinson's disease? So Parkinson's disease is a neurodegenerative disorder. It is heterogeneous, which means that it is complex, can be caused by many factors, and shows significant variations in symptoms and progressions from patient to patient. And the main feature of Parkinson's disease is the loss of dopaminergic neurons in the area of the brain called the substantia nigra in the nigrostriatal pathway. Here is the substantia nigra and nigrostriatal pathway. And the loss of those neurons is evident in the major changes of the brain and in symptoms, in two groups of symptoms. So the first group of symptoms are the motor symptoms, which are bradykinesia, which is in simpler words slowness of movement, general rigidity, tremor or postural instability. And those motor symptoms are often accompanied by, they don't have to be accompanied with the non-motor symptoms such as depression, sleep disorder and cognitive changes. They are like broadly defined cognitive changes. It really depends on the particular person. And so Parkinson's disease does not in itself necessarily lead to life shortening, but it does cause a rapid decline in the quality of life, both of the patients and the family of the patients, because patients themselves have the ability to carry out even the most basic daily activities and functions. So why is this topic so important? Because it is not just a regional issue, but Parkinson's disease is the second most prevalent neurodegenerative disorder in the world, surpassed only by Alzheimer's disease. And it is commonly but mistakenly recognized and considered as a disease of the old age, which is a significant barrier to recognize its true impact and changing the social perception of this disease. And what separates Parkinson's disease from Alzheimer's is that even though we have made considerable progresses and developed some disease-modifying therapies for Alzheimer's, there are no disease-modifying therapies to slow the progression of Parkinson's disease. We only do have therapies that alleviate the symptoms, so they don't stop the ongoing progression of the disease and ongoing degeneration. So in fact, they do not address the disease itself. So now I would like to focus a bit on the therapies that are currently used in the Parkinson's disease. So the most commonly used therapy is L-DOPA, known as levodopa, which promotes dopamine release in the brain that compensates for dopamine deficiency caused by neural loss in the substantia nigra, and it most often provides the relief from motor symptoms such as bradykinesia, rigidity, so it does improve the quality of patient's life. However, there are some problems with this method because long-term use can lead to significant complications and side effects such as fluctuation in symptom control, some reappearance of symptoms before the next dose of the treatment, or the development of levodopa-induced dyskinesias, which are involuntary movements. So what can we do if we don't want to use L-DOPA or we just want to delay the administration of it? We have other methods such as dopamine agonists that work by directly stimulating dopamine receptors, and they are sometimes used alone in the early stages of Parkinson's disease to delay the need for L-DOPA, and they generally have a lower risk of dyskinesias but may cause some other side effects like hallucination, excessive sleepiness or impulse control disorder, and they also are considered less effective than levodopa because they do not replace dopamine. And even though we have those two therapies that are considered effective in alleviating the symptoms, they do not reverse or stop the ongoing neurodegeneration, so in fact they don't address the disease. So that's the reason why researchers nowadays are trying to find some alternative strategies. And one of the most promising ones is the one involving stem cells that could potentially replace degraded dopaminergic neurons and restore brain function at the cellular level. So what are stem cells? So they are unique, undifferentiated cells found in both embryos and adults. And they have two main properties, which are self-renewal and differentiation. And now I would like to focus a bit on self-renewal, which mean that they can divide and produce more stem cells over really long periods of time. And we have two methods to do it. We have symmetric division, where we have creation of identical daughter stem cells. And also we have another method, which is asymmetric division, which creates one stem cells and one undifferentiated progenitor cell, which has limited differentiation capacity in the future. And apart from these self-renewal properties, we also have differentiation properties, which mean that cells can differentiate into some specific cell types, such as nerve cells, blood cells, or liver cells, depending on the signals they receive in the treatment. And the process of this differentiation into neurons is called neurogenesis. And neural stem cells, so the one I decided to focus my research on, are capable of generating the three main types of central nervous system cells, which are the neurons, which transmit signals, astrocytes, which support and regulate the environment, and oligodendrocytes that form the myelin, isolating neural axons. Myelin is really important in passing by the neuroinformation. And the neural stem cells can not only differentiate into other cell types, but they can also alter the environment where the cells are placed. So thanks to it, they can regulate the activity through signaling involving neurotrophins, neurotransmitters such as GABA, which is inhibitory transmitter, and molecular pathways, and that can balance proliferation and differentiation. And in the process of differentiation, it's important to understand the potency of the cells, because we have totipotent stem cells, pluripotent stem cells, multipotent stem cells, oligopotent stem cells, and unipotent stem cells. All of them differ in their way and in the specific cells they could potentially differentiate to. So I will focus right now on stem cells used particularly in Parkinson's disease. So we have many complex divisions of stem cell within stem cells, as I said, depending on, for example, potency. But from a neurobiological perspective, we mainly focus on three types of stem cells. And the first of them are embryonic stem cells that are from early stage embryos and are pluripotent, meaning that they can become any cell in the body. It will be really important later in the presentation. Then we have adult stem cells that are found only in some specific tissues and are multipotent, so they are more limited if it comes to their differentiation. And scientists have developed induced pluripotent stem cells that are like genetically reprogrammed adult stem cells that are really similar in their function to embryonic stem cells, but they don't have this problem of using embryos. So now I'll try to cover all of them more in detail. So we have human embryonic stem cells that are pluripotent, as I mentioned before, and they can self-renew and differentiate into any cell type, including the midbrain dopaminergic neurons lost in Parkinson's disease. And recent advances has shown that scientists can generate specific subtypes of neurons, because we have many types of neurons, and they can generate A-type dopaminergic neurons, which are most commonly found in the Parkinson's disease, and they can mimic the embryonic brain development and the environment found there. So There were some clinical trials that used those embryonic stem cells, and they showed that by using cells-derived dopamine progenitors, we had really promising results. For example, we had one research where it was in phase 1, and it involved using bilateral transplantation of cryopreserved human embryonic stem cells, derived dopaminergic progenitors, and they were placed into putamen, and it demonstrated no serious adverse effects. And also we had increased dopamine uptake in PET scans, so the method most commonly used while thinking of using PD treatments, and it was done after 1 year, and it shows some alternative. But the problem with this method, because it would be perfect, but it requires immunosuppression because we have allogenic origin of the cells, so it raises also some ethical concerns connected with using embryos, and what's more, it's really expensive in creating the appropriate cells, so it's really small likelihood of this applicability. And we have another method that is using mesenchymal stem cells, which are multipotent, and they are found, for example, in bone marrow, adipose tissue, or cord tissue, and due to the fact that they are multipotent, they cannot really differentiate into all types of cells, so they also cannot differentiate into dopaminergic neurons, so their function lies more on the neuroprotection. And they can secrete neurotrophic factors, anti-inflammatory cytokines, and extracellular vesicles that reduce neuroinflammation and modulate the brain's microenvironment in the way that may favor neural repairment, so they can potentially slow degeneration. And the last type of stem cells, which also I decided to focus the biggest part of my article on, are the induced pluripotent stem cells that are created by reprogramming adult stem cell directed, and they also can be directed into A9 dopaminergic neurons. And we have some really important advantages of using induced pluripotent stem cells, which are, for example, the fact that they are patient-specific, they can reduce or eliminate the need, and also they can reduce or eliminate the need of immunosuppression. So they resolve all the problems that were in those two I mentioned before. But of course there are also some significant challenges. For example, we need to ensure that reprogramming and differentiation process eliminate the risk of tumor formation. It's one of the biggest risks connected with using stem cells, because right now scientists don't really know, as far as I know, they don't really know how to control stem cells, because when we put them into some region in, for example, the brain, then they can later on be differentiated into other forms of cells. And also current research has to focus more on making the whole process of reprogramming cells more cost-effective and time-effective, but they are, at the moment, induced pluripotent stem cells are considered the most promising ones, so I will try right now to explain more the process of reprogramming them. So at the very beginning, the process of obtaining induced pluripotent stem cells starts with collecting adult cells. It can be from skin or blood, it doesn't really matter. And then we reprogram them using Yamanaka factors. And those factors can alter epigenetics markers such as DNA methylation or histone modification to reactivate those genes that are connected with potency and pluripotency in general. So once we have induced pluripotent stem cells, using those pluripotency markers, the next step is direct differentiating into dopaminergic neurons. Is it working? Yeah. So at the very beginning, those cells are cultured in the medium that inhibits pathways, keeping them in the undifferentiated stage, which is known as neutralization, and then they are exposed to some molecules such as fibroblast growth factor 8, which promote ventral midbrain identity, and it also mimics the embryonic conditions that are needed to create the A9 dopaminergic neuron and to ensure their correct development. And then we have the phase that promotes neural maturation using factors like ascorbic acid, cyclic AMP, and laminin. And it takes from 10 to 20 days depending on the researcher conducting this some study, and their cells have to be tested before being placed to the body, and they have to be tested for markers such as the tyrosine hydroxylase, which is the enzyme involved in dopamine synthesis. And before transplantation, those cells have to undergo some strict testing to ensure purity, safety, and absence of some undifferentiated cells that could form tumors, as I mentioned before. And the neurosurgical procedure itself involves delivery into dopaminergic precursors into patient's brain, into this region, which is putamen, which is the region of the brain that is in the midbrain, which is most commonly affected in the Parkinson's disease. And the goal for those cells is to make them survive and mature into functioning dopaminergic neurons, which could later on be integrated into existing neural circuits and restore dopamine levels. And all of those makes it that the research and the paper I'm writing is most centered on the induced pluripotent stem cells rather than those two that I mentioned before. And right now I would like to summarize it a bit. So we have some advantages of using stem cell-based therapies. Now I'm talking about stem cells therapies in general, because I'm writing meta-analysis which compares all the treatments available. So they have the potential to restore lost dopaminergic functions. They can address disease cause, not the symptoms. We have a possibility of long-term improvement, not just the symptom alleviation, which would happen in L-DOPA. And induced pluripotent stem cells offer personalized treatment with low immune rejection. And if it comes to the disadvantages and limitations, we have major ethical issues in the context of human embryonic stem cells. We have potential tumorigenicity, which happened in the research and the papers I read. They are really expensive in clinical trials, and we have complexity and time. It is just a complex and time-consuming process of changing the normal cells found in the body into pluripotent stem cells. And also, right now, we don't really have specific procedures to be conducting this method. So in general, we don't have phase 1. We only have phase 1 and phase 2 clinical trials. At the moment, we don't really have any phase 3 clinical trials, which means that the tests were conducted only on small groups of participants, and it was focused more on the side effects rather than comparing it to other treatments like L-DOPA. So we can't really say if those results are fully reliable, and it's something to be tested in the near future. And at the moment, here are the advantages and disadvantages of all those 3 stem cells that I mentioned before, but I will talk only about one of them. So induced pluripotent stem cells are the most faithful one at the moment, and they are in phase 1 and phase 2 clinical trial. The latest article from Nature came in May, and it was in Japan when autologous induced pluripotent cell-self dopaminergic progenitors have been transplanted into putamen of the patients, and the data was collected after 2 years, and there were no major adverse events, and some patients shows the mild motor improvement. So the general conclusion to all I said is that Parkinson's disease is still a big challenge, both medically and socially, and although current pharmacological treatments can alleviate motor symptoms, none of them can stop or reverse the underlying issue, and it is really important to focus on therapies, for example cell therapies like stem cell therapies, that could potentially help in addressing the issue, not the symptoms of the issue. And if it comes to the future of the stem cells, stem cell therapies in general, especially those using induced pluripotent stem cells, are the real hope for shifting this treatment paradigm, because we could potentially shift the treatment from symptomatic relief to potentially disease-modifying solutions. And there are many challenges, as those I mentioned before, such as long-term safety, functional integration, and large-scale application. But early clinical trial results are truly promising, so this should give us some faith that those therapies could potentially one day make a better future for Parkinson patients. Yeah, and that's all I wanted to say. Thank you for your attention.